Studies over studies have shown that if you are not getting enough sleep, you are more prone to have about tenfold increased risk of depression and anxiety. Treating your insomnia may help improving the symptoms of your depression or anxiety. Medications are okay for that short term, but long term, medications is never the correct answer. I tell my patients, Ahmed, bed is a place to only sleep or have sex, nothing else. So you're not going to be eating in your bed. You're not going to be watching TV in your bed. If TV is in your bedroom, kick it out of your bedroom. Light is your biggest enemy to your sleep. So try to avoid those things. If you're not able to fall asleep, leave the bed, go do something else. Don't watch your favorite show on Netflix, but do something boring and come back to bed only when you're tired and sleepy. Patients would cook in their sleep, and there have been cases where people have burned their kitchens. You're eating ice cream, you're watching Netflix, and then you're going to bed. It's not good. Every time any kind of artificial light that goes through your retina, it activates your optic nerve and suppresses the melatonin release. I think he's dead, so I have to wake him up. And then suddenly you start gasping. Suddenly your muscles open up and you start breathing, your oxygen levels go up, your heart rate goes down.
Welcome back, everyone. This is our second session of Sleep Medicine podcast with Dr. Mahmood. Like I said, has kindly agreed to give us some more time to ask a few questions that we were not able to discuss in the first session. So, welcome back again, Dr. Mahmood. Thanks for your time.
Thank you, Emma.
All right. So, one more question before we delve into the high yield stuff that people really want to know. What are the things that work for sleep? What are the things that don't work for sleep? One more question that I wanted to ask you the last session, but couldn't because of the time, is does the lack of sleep or not getting enough sleep affect your mental health, the risk of anxiety, depression, or social interaction problems, things like that? Does it have any bearing on that?
That is a very good question, an important one, Ahmed. Lack of sleep is linked to psychiatric diseases. Unfortunately, this is a fact, and it's a bidirectional traffic. It's a problem that lack of sleep leads to more anxiety, so it's like a vicious cycle, and that anxiety leads to more insomnia problems. Studies over studies have shown that if you are not getting enough sleep, you are more prone to have about tenfold increased risk of depression and anxiety. And that is where it comes that there are certain medications which are used to treat depression or anxiety, which also hit the insomnia problem. So it's really important to bring that as one of the symptoms of your psychiatric illness could be insomnia. Most of the time, this is what we see, and treating and telling your doctor, your physician, be it a psychiatrist or a sleep specialist, about a coexisting psychiatric problem or a coexisting sleep problem, if you are seeing them for a psychiatric issue, would help them treating them, because treating your anxiety would help with the quality of sleep, and treating your depression may help with the quality of sleep, or the other way, treating your insomnia may help improving the symptoms of your depression or anxiety. So it is very important question that you brought up, and needs to be mentioned and revealed to your doctor, whoever's treating your problem, so that they can basically kill two birds with one stone.
That's good to know. So now moving on to the things that can help you sleep. So a lot of people don't want to take medicines. We will discuss the medicines towards the second part of our discussion. But what are your high yield recommendations, the top three, top five things that you tell your patients? And you sound like a broken record telling everyone to do the things that are supposed to help for majority of the patients, majority of the population with getting a good night's sleep. What are your top three, four, five recommendations that can help people get a good night's sleep and perform better during the day?
Extremely important, and the most common question that we get, the most common type of patients we see in sleep clinic are with insomnia. How to improve the quality of sleep, how to get the amount of sleep that we need to function properly. Medicines is an easy and a short answer, but it's very incomplete answer. I tell my patients who have insomnia or sleep-related difficulties, whether it be going to sleep or staying asleep, called sleep onset insomnia and sleep maintenance insomnia. These are habits, basically, which are developed over years, and they don't develop, unlike acute insomnia, which could be related to a stressor, like I have difficulty falling asleep for the last 1 month or for a couple of weeks. That is a different problem. Medications are okay for that short term, but long term, medications is never the correct answer. So, first of all, there is something we call sleep hygiene. It is very important. It's like your pre-sleep time should be a ritual. How do you make that environment more conducive to get the best sleep or to fall asleep? Just like anything we do, if we have to go to work, we get up, we get ready, we have to shave, we have to brush, we have to eat breakfast, get nice clothes. Same way, sleep, you should have your environment very conducive to fall asleep. For example, your temperature of your room, the amount of light you have in the room,
Mm.
so the amount of noise level and distraction you have around is very important. And consistency is the key. Not like you're sleeping at 9 o'clock, tomorrow you'll sleep at 11 o'clock, on the weekend you're going to bed at 1 a.m. No, consistency is the key. So your body needs that same time to have the best out of that sleep. So consistency is my first recommendation. Do your prerequisites to go to bed, the environmental things that you need, optimal environmental conditions that you need. And I tell my patients to like wind down before you go to bed. Keep another 30 minutes for your stressors. Don't think about stressors. There are some anybody can YouTube. There are some breathing exercises which do help. For chronic insomnias, yes, we do use sleep medications, but we always use them in conjunction with something we call cognitive behavior therapy for insomnia. It is a very comprehensive treatment, and studies have shown that people who do a combination of CBTI and sleep aids or hypnotics tend to do much better compared to either one of them alone. Because remember that some of these medications, almost all of them, have certain side effect profiles and they're not safe. Some of them are habit forming, and we can go into details about those medications. But just to tell you, just to summarize it, that cognitive behavior therapy for insomnia in combination with medications and sleep hygiene is the best modality available to help with patients with insomnia. Now, cognitive behavior therapy has one important component is sleep hygiene, as we just talked. What are you eating before your bedtime? What is the duration? What is the interval between your bedtime and your snacking? What are you snacking on? Are you doing some exercise? Are you in front of a TV, for example? Are you playing a video game or you are on TikTok on your phone while you're in the bed? Those are very important things. Specifically about the cognitive behavioral therapy, there are different techniques. For example, stimulus control, which it means that if I go to bed and I'm not able to fall asleep roughly for 20 minutes, 30 minutes, I need to leave that bed because my mind has developed that association with the bed of going to bed and thinking about something, about rapid thoughts, about random thoughts, or being on my phone or my iPad or reading ebook. For example, ebooks. There have been studies which have shown people who read ebook versus people who read textbooks. There is reduced REM sleep, there is increased sleep latency, there is decreased sleep efficiency in those patients. Not only that, they tend to do poor next day in terms of their vigilance. It does affect their day's activity, next day's activity. So CBT has various components to it, and it does work, but it does need some commitment and it does need some patience because these are the habits I always tell my patients. These are the habits you developed over 10 years, 15 years. They're not going to change overnight. So persistence is the key, and consistency with your sleep routine is the key. Following those sleep hygiene, and I was just touching base with stimulus control. So I tell my patients, if you're not able to fall asleep, just don't keep looking at your clock or your watch, because that provokes more anxiety. And
Mm.
that anxiety leads to more inability to fall asleep. Oh my God, it's been 20 minutes, 30 minutes. I'm not able to sleep. What's going to happen? Am I going to die? No, nobody dies from lack of sleep. Okay.
Good to
So
know.
real important thing is that you roughly in your mind, you would know, okay, this has been about 20 minutes. I'm not able to sleep. And I should know that bed is I tell my patients, Ahmad, bed is a place to only sleep or have sex, nothing else. So you're
Mm.
not gonna be eating in your bed, you're not gonna be watching TV in your bed. If TV is in your bedroom, kick it out of your bedroom. It should be in your living room. You should not be watching on your phone. You should not be playing games on your phone. You should not be on TikTok or anything like that. Light is your biggest enemy to your sleep. So try to avoid those things. If you're not able to fall asleep, leave the bed, go do something else. Don't watch your favorite show on Netflix, but do something boring and come
Mm.
back to bed only when you're tired and sleepy. And it will happen. It will require some commitment. It will take some time, but eventually it will happen. The goal is to improve sleep efficiency, which means that amount of bed you spend in time, which is spent in sleeping. That is your sleep efficiency. So
Mhm.
gradually it will happen. There are other techniques which we probably will run out of time, but there are some free apps you can download for CBTI, for insomnia, and they are very self-explanatory and can help. And if it doesn't, tell your physician to help you with that and maybe get a sleep referral so we can go over those things.
Can you suggest a couple of apps that people can download, something for free that?
Yeah, there are some VA generated apps. So you can, if you go to the App Store, you can type CBTI for insomnia and you will pull a bunch of them. I remember one of them, the VA one that I recommended some of my patients to receive, a very common insomnia problem related to PTSD and other psychiatric issues in veteran population. So you can download those. I don't remember any particular in my mind yet at this time, but if there are a bunch of them, I have once looked at them, and all of them are good and very user friendly.
No, we see
Uh,
ads for Calm, the application called Calm on TV. I've never used it, but I don't know if it is something that really helps people fall asleep, or is it one of those like white noise things that may work for some people and not work for others?
yes. So it is again, there is no one simple pill that will fix the problem. There are multiple techniques and they all have to be done simultaneously. You mentioned white noise. Yes, I tell my patients not to listen to music because anything that has a pattern, the brain gets involved with that. Ultimately, some people have come to me and they've told me they listen to this maybe a 90-minute Bible story and then they have insomnia.
Mm.
So something is absorbing and I'm listening to it. Something is giving me is interest creating and it's actually involving me, which has a pattern like music or like a story that is interesting. It's gonna just delay my ability to fall asleep. Eventually, I'll fall asleep, but if I'm not doing any of these things and my mind is clear of those thoughts, I may be able to fall asleep earlier. I tell that if you really have to resort to any of those techniques, white noise or any kind of noise which does not have a pattern, Emma, probably are using some white noise for your kids nowadays. I have used them and they just work fine.
I don't know.
Um,
We have dark noise in our home, the kids screaming and all. No white noise. But that's a good suggestion. Like you don't want to be doing something really interesting. So you did mention some foods that you want to watch out for to help improve your quality of sleep. So what are some of the foods that you suggest to avoid before going to bed? And if there are any foods that you recommend eating or some beverages that help you sleeping a little bit better?
Yes. Do you want to talk about briefly about the medications, hypnotics, or do you want
Yeah,
to?
definitely. We want to. Yeah, that's the next
Okay.
on the
Yes,
on the.
I briefly touched that about medication, so I
Yeah, yeah.
think
We will
it
definitely
will
go into
be
a little bit more detail because a lot of patients ask about these medications, and
yes.
we want to go over them. Hopefully, especially the popular ones, to see if they are any good or not. But yeah. we will have some time for that.
Okay, so I'm going to divide quickly them into over-the-counter available medications, and then there are some herbal remedies, and then there are prescription medications.
Okay.
And so briefly, over-the-counter, we see the most common is melatonin. Nowadays, people are using a lot more magnesium, and then magnesium has several compounds. Magnesium glycinate is one of the most common ones. There are sprays available, there are capsules available. The problem with any of those compounds is that they work. I'm not saying that they don't work, and there is some evidence. There on magnesium, for example, there was a double-blind randomized controlled trial done a decade ago almost, which showed that it tends to improve the sleep quality, the sleep duration, improve sleep latency. And there are scientific basis for using it. There's scientific basis for having glycinate as mixture with magnesium than having oxide or citrate. Being nephrologist, nobody knows better than you about these electrolytes.
Yeah, being a
Um,
nephrologist, I just want to do one disclaimer. Don't take these medications if you have kidney disease, especially the magnesium, without talking to your doctor. But yeah, if you
okay,
don't have
good.
kidney disease, yes.
Very good. So that takes us to another important fact that we don't know how these compounds are regulated. Some of them are not FDA regulated. For example, melatonin. We know melatonin is important to induce sleep. It regulates your circadian rhythm. But the compounds we get, there have been studies which have shown that the amount of melatonin labeled on the bottle may be anywhere 80% less than actually depicted on that compound, up to
Okay.
480% more than what is labeled. And
That's the
really,
over-the-counter melatonin.
absolutely melatonin. And the
Wow.
amount of melatonin you need is much less than actually that is labeled on there. For example, 5 milligram tablet. You don't need 5 milligram for melatonin for insomnia problem. And then if you
The
really have to take
milligram?
melatonin, there
Yeah.
are some prescription melatonin agonists like Ramelteon, which is used at much less dose, like 2 milligram, 3 milligram dosing. And the timing of it, how you take it, you can't just take it and go to bed at 10 p.m. because you have to understand when is your circadian rhythm, when is your release of melatonin happening, which is typically about 2 hours before your intended bedtime for it to work. And so these are over-the-counter sleeping aids. And then some people have used Tylenol PM, which has some antihistamines added to them, which are FDA approved for this purpose. But really, we need to look at the population which is using it. For example, if it's your 70-year-old patient who is going to use it, who is on a bunch of other medications which have antimuscarinic side effects. So these medications can lead to increased constipation, drowsiness next day, and dry mouth and all those side effects. And then there are some over-the-counter remedies available. For example,
Before,
chamomile tea.
yeah, before you talk about that, I want to highlight the thing that you just said because this is something I didn't know as well, that the melatonin prescription is probably better than over-the-counter melatonin. Because if someone asks me for a prescription of melatonin, I would usually just tell them, "Oh, it's over-the-counter. Go ahead and take the over-the-counter medication." So for the patients to ask their physicians for a prescription instead of buying over-the-counter stuff that may not have the dose depicted, and for the physicians to know that the prescription is probably better than recommending over-the-counter melatonin. So
Yes,
that's very
yes,
important. Thanks for sharing
yes,
that. Yeah.
absolutely. And these things, melatonin, be it magnesium glycinate, be it chamomile tea,
Yeah. So
or
chamomile tea, how about the chamomile tea? So does it work or is it something effective?
technically, there is a compound which is a flavonoid in it, and it does tend to bind with the benzodiazepine receptors in brain. So it does have a modest effect. It does, and I've tried it. It did work for me. So it does have a modest effect. But if you look at the evidence, we always talk about evidence and scientific proof to it. There is not much strong evidence. These things do have modest effectiveness, and they are overall, generally speaking, they're safe. They have a safe profile. For example, melatonin has a safe profile. People get side effects of maybe daytime drowsiness or may have headaches,
Mm.
but overall, they don't interact with many other medications they are taking. They can't, except if you ask me about kava tea, it has been proven to be hepatotoxic. So I will discourage using kava, KAVA,
It's
and
not the kava that we drink in
no,
Pakistan.
not the kava we
The
drink.
kava.
That's why I had to.
The
No,
kava
not that
is
kava.
okay.
Kava
I
tea.
got scared. Because we
Kava
drink
tea.
kava to just to digest all the curries that we have eaten, and multiple times a day. So not the kava.
Not that kava.
Okay.
And then the other medications are, for example, the other category of the medication is prescription medications. And even in the prescription medications, there are some which were used for other purposes, and their side effect is causing sleepiness. So they're off-label use. For example, the most common of them is trazodone, which
Mm.
is an antidepressant medication, but one of its side effects is causing sleepiness and or somnolence. So it is used sometime. I see a lot common in primary practices. Some of the APPs prescribe it, but the dose used for insomnia, trazodone dose, is much less than the used as an antidepressant. But again, it can have side effects. For example, daytime drowsiness and headaches. And then sometimes you have to go up on higher doses. So it's not FDA approved for this purpose, and it's not under any ASM guidelines. They don't endorse them. They're not strong evidence to support that they should be used only for insomnia purpose. But again, they're used. Then, for example, for Seroquel used for as an antipsychotic, one of the side effects is causing sleepiness. So it is commonly used in practice. Then there are medications which are purely made for insomnia. I forgot to talk about our most favorite benzodiazepines like
Yeah.
lorazepam, Xanax.
Ambient, like people ask about, can I get some ambience? Yeah.
So Ambien is a little bit different. Ambien is a non-diazepine, but it works on benzodiazepine receptors, and it is called non-Z drugs or Z drugs, non-benzodiazepine Z drug. Compared to pure benzodiazepines like Xanax or Ativan,
Valerian.
or lorazepam or mazepam, for example, these are less habit forming. They don't come without their own set of side effects. First thing we need to realize that these are Ambien, for example, or Lunesta are short acting. Unless even if you go to their XR releases, they're not very good for sleep maintenance insomnia for people who really keep waking up in the middle of the night unless they have no other issue that is causing that. For example, untreated sleep apnea. They're relatively safe medications. Like they don't suppress respiratory drive too much. So they're relatively safer for people with advanced lung disease, for example, compared to benzodiazepines,
Mm.
which are, I've never prescribed a benzodiazepine for insomnia. For short term, I would not say that Restoril, you can't use it. For example, you have a patient in the hospital who's complaining of insomnia, and you can use for a day or two if they haven't slept. It is okay, but they're habit forming. They develop tolerance, so you have to go up on higher doses because they stop working at certain doses. And then studies have shown when I was a critical care fellow, we were told and we looked at a lot of literature and found that use of benzodiazepines, for example, as a sedative in ICU on mechanical ventilator patients do tend to cause structural brain damage.
Mm.
So long-term use of benzodiazepines is extremely discouraged. So
And
short term is
how long is long term? Like how many?
we're talking if you have to give it to someone, give them for a week supply or 2 week supply, and that's it. For acute insomnia, it's fine. For not for chronic insomnia, I would not give them a monthly supply and keep refilling them. So there are other drugs like we talked about Ambien, Lunesta. One caution I would tell if some physicians are listening, primary care, especially if they're listening to this podcast, is to use the least possible dose. Start always with the lowest dose, and then titrate up, especially for women. These Ambien or Lunesta, you want to use zolpidem or ziplectone or acipeclone, you have to use the lowest, start with the lowest possible dose, especially in women and in older people, and then gradually titrate it upward. The common side effects of these medications are basically can be parasomnias. I have patients, they would sleepwalk on these medications. Patients would cook in their sleep. And there have been cases where people have burned their kitchens. So have to be careful and have to have those disclosures with the patients. And some patients tend to do good on them. Mostly, I'm not talking about these parasomnias are rare, but they have been seen in 1 to 3%, 4% of these populations. You know, that's a good number in your
Yeah.
practice. Then there are certain medications which recently come up, orexin receptor antagonists or double orexin receptor antagonists. So orexin, to understand this, what is orexin is a neurotransmitter in the brain, which has a malfunctioning or shortage in people with narcolepsy. We see in narcolepsy, these neurotransmitter or their receptors are damaged or the release is malfunctioned in narcolepsy. So they tend to sleep more. So it means that if you tend to block these receptors by somehow, these patients with insomnia will tend to sleep more. So that leads to some neuromedication. For example, common is Belsomra. Again, safe side effect profile, tends to work really good. The problem is insurance. So for insurance purposes, you have to start with medications which are more common, like Ambien, and then you have to have tried Lunesta, and you have failed, and then you can go to Belsomra. So these medicines work, and they're obviously contraindicated in narcolepsy patients. But then again, for most of these medications, you have to tell your physician has to look at what other medications you are taking, because some of them they interact with your other medications and can suppress the effectiveness or can increase the effectiveness of other medications. So the dose adjustments are needed.
So the
Um,
orexin inhibitors are pretty new because I haven't seen anyone taking Umbra or I know Devigo and there are a couple of other names that come up, but I've never seen anyone using these. So you have some patients who have tried these medications and they work pretty well.
We have, and they're relatively new. I have seen them in my fellowship, it was back in 2018, and then when I was practicing in Tyler at UT, we had used them some. So it is about more than 5 years old. So relatively new, as you said, but they tend to work good and their safety profile is reasonable.
They don't cause daytime drowsiness, like you can go to work or you can drive in the morning.
Typically not because they're short acting. And we tell our patients obviously not to take at midnight.
Yeah.
You take them early. And obviously your sleep hygiene tells you to go to bed around 9 or 10 p.m. So you take the medication at 8 p.m. and then go to bed.
And do you develop tolerance over time to these medications as well? Are
Not
they
really.
forming or they are different?
Not really. They're not habit forming. Same goes with Ambien and all these. They're not habit forming. There's no cravings for it. There's no dependence on them. They have less abuse potential.
So we discussed a bunch of things, but to wrap up the things that help you sleep. So of all the things you mentioned, chamomile tea, magnesium, melatonin, the prescription medication, what are your go-to recommendations when it comes to using something to help you sleep? Where do you start and or is it all individual and it can be different in every different patient?
So let me go back to, I think we had a question you asked me earlier, and I went back into the medication side about the diet.
Yeah.
So I'll take you back to the diet because I think it will help us summarizing everything. Yes, don't personally tell patients to eat one thing or the other thing. Your diet is important overall for your well-being anyway. But people ask me, okay, can I drink warm milk? Does it help? Can I drink things which have more melatonin, like cherry tart, kiwi juice, tend to have more melatonin in them. And I have few friends who are using it actually, and it tends to help them. They talk highly about it, but scientifically speaking, do I have high evidence? Yes, same way goes for magnesium. Diets that can contain high magnesium, diet that contain complex carbohydrates, for example, sweet potatoes, brown rice. Scientifically, they show that they help tryptophan, serotonin cross your blood-brain barrier, tryptophan especially. So that certain diets which are rich with tryptophan, and for our audience, tryptophan is an amino acid that is required to build serotonin, which is then converted into melatonin, which induces the sleep. So diets which are rich in tryptophan, your warm milk, your turkey meat. You may have heard after Thanksgiving break, people sleep a lot.
We sleep a lot, but
So tryptophan rich, magnesium rich diets like avocado, almonds, as I said, complex carbohydrates, Nuts, which are high in tryptophan, again in melatonin, poultry, chicken meat, they're high in tryptophan. And but the most important thing is what you are, it's not what exactly you are eating specifically, it's what time you are eating and how much you are eating. So that takes us back to your, I'll revert back to your question that you just asked, that what are the top tips you can do? Consistency. If I have to tell you, consistency of your sleep routine. What you're eating is important. It is more important when are you eating. Are you eating it at 9 p.m. and then going to bed at 9:15 is not good. Your body needs a time to process those things that you have taken. Avoid too much starch or heavy sugary products, processed products closer to bedtime. Avoid snacks. You're eating ice cream, you're watching Netflix, and then you're going to bed is not good. Drinking too much fluids before going to bed is going to keep waking you up. The kidneys are not going to sleep. They're going to keep producing urine and you'll have to wake up. The other thing is your environment. Just we talked about sleep. Make some rituals before sleep. You need a dark, cold, and quiet environment. I don't want you to be a 30-degree freezing room, but an optimal temperature, 65 to 70 degrees, that induces sleep better, that relaxes your body. Wind down, do some breathing exercises. Keep your time for yourself. Avoid light. The most important, you briefly mentioned in first session about blue light. I can't tell you how many times I ask patients, we can't sleep. What are you doing in your bed? Oh, I try to watch YouTube, or I watch TikTok videos, or I'm on Facebook or reading ebook. Every time any kind of artificial light that goes through your retina, it activates your optic nerve and suppresses the melatonin release. Is the enemy of sleep. It suppresses your, as we just talked, watching, reading a ebook or watching TV, it delays your circadian rhythm about 45 minutes. So every time before going to bed, you do that, your natural release of melatonin that's supposed to help with the circadian rhythm and induce sleep is advanced by about 45 minutes. Obviously, you are not doing a favor to yourself by doing those things. So that is very important. Quiet environment. Too much noise. I can't sleep in too much noise. Some people can, but again, generally speaking, for general audience, this is the most important thing. Consistency, your environment, and morning. If you wake up in the morning, try to get yourself exposed to more light. That is important. And some of the circadian rhythm disorders we treat with light, be it in the evenings, be it in the mornings. But morning light is really good. You want to go for a walk, do that. It is part of those healthy habits that keeps you healthy overall, not just your sleep. And try to have 7 to 8 hours of sleep.
Excellent. So, last 10 minutes of our discussion, now we talk specifically about your area of expertise. And two of the common problems that we see in our practice, one is sleep apnea, and the second is restless legs. So, just briefly talking about sleep apnea, because a lot of people snore at night. When do you start thinking that this is not a regular snoring pattern and this is something that needs more investigation? It may be part of the sleep apnea syndrome and needs to be seen by a sleep specialist like yourself. When do you start getting concerned about sleep apnea?
Very good. And you said that I get a lot of referrals from our nephrology friends about these two issues. Sleep apnea or obstructive sleep apnea, there are different kind of sleep apneas, central sleep apneas, obstructive complex sleep apneas, but strictly talking about obstructive sleep apneas, it is a self-explanatory term. Obstruction in your airways happening during sleep that leads to apnea or cessation or slowing down of the airflow going into your lungs. Our airways here are not solid pipes. They're a bunch of muscles wrapped around each other, especially the upper part of the airways, and they're stabilized by nerve signals coming from the brain and keeping those muscles open. During certain stages of sleep, these muscles are are toneless, or they lose their tone. Just like you lose tone in your limbs, in your arms and legs, these muscles lose tone. The way lungs breathe, they generate a negative pressure. So they suck the air in from the environment. It's just like a paper straw. You take a paper straw and you suck fluid quickly and forcefully. The paper straw impinges, it becomes narrow. When your airways are narrowing down, you produce sound called snoring. So most of the snoring is coming from here, not from here. And then when they completely close, you actually no airflow into your lungs. So your lungs are not getting air and
Mm,
your oxygen levels start declining slowly. Brain is very sensitive to those low oxygen levels.
mm,
So it thinks that heart is not doing what it's supposed to do. Your heart rate goes up, your blood pressure goes up during those times, those few seconds. Finally, the brain realizes, okay, that's not the problem. The problem is these muscles are closing up and it wakes up. So sleep fragmentation happens. So your sleep is disrupted. The amount of sleep you think you are getting is not there. So your brain wakes up, gets these muscles back in action. Most of the time, we don't realize that we are waking up, but
mm,
actually our brain is waking up. So that's called sleep fragmentation. And most of the time, I hear from the partner, he or she says, "Oh, I have to move him because he stops breathing. I think he's dead. So I have to wake him up." And then suddenly you start gasping. Suddenly your muscles open up and you start breathing, your oxygen levels go up, your heart rate goes down. This cycle continues throughout the night. Every time
mm,
your oxygen levels drop, free radicals, which are harmful byproducts, are released in the tissues and they cause damage. That leads to increased dysregulation of metabolism, uncontrolled blood pressure, diabetes, risk of cardiovascular comorbidities go up. What are the cardinal symptoms you should be looking at?
mm,
Daytime sleepiness. You slept for 6 hours, 7 hours, 8 hours. You wake up, you're still feeling groggy. You may have morning headaches. You may have dry mouth. You
mm,
have difficulty concentrating. You have difficulty remembering things. Most importantly, is the fatigue and daytime sleepiness. You are taking naps. I always tell my patients, 40 years old, you are taking nap in the afternoon. That is pathological. That is not normal
mm.
because naps are only for kids less than 5 years or people who are over 65, 70 years old. So that is the one few of the symptoms I want them to look for. And if they develop those, they need to be screened. Risk factors for sleep apnea, most obvious that people talk about is obesity or having a high neck circumference, but that's not the only factor. I've seen severe sleep apnea in BMI of 25.
Mm.
So it's
So
not,
sick people. Yeah.
it's a complex physiology and it depends upon the interplay between the neurological signals and what is the peak crit or critical pressure where your airways close versus how much force is being applied to keep them open. These are all interrelated, and it's very important if you have any of those symptoms. Some patients are referred to us from our cardiologist friends for uncontrolled blood pressure, even from nephrology. Treating sleep apnea does tend to help with some of the uncontrolled or malignant hypertension by about 5 to 10 millimeter of mercury in studies on journal. Then some arrhythmias arise from untreated sleep apnea. Like we see a lot of atrial fibrillation common in this population, and they keep ablating them, treat them with radio frequency, and then they go back into those arrhythmias because of that stress that is created during sleep from untreated. Imagine that, Ahmad. This is like Mother Nature, which is strangulating you in your sleep. This is the same picture. This process happens in severe sleep apnea more than 30 times in an hour during your sleep.
Yeah.
So more than 30 times, you're actually dipping your oxygen levels and struggling to breathe, your blood pressure having all those fluctuations. It's actually worse than during the daytime. So imagine that same machine which has to slow down for those 7, 8 hours for rest is actually doing more work during those sleep.
And
So
more
you need
strain
to
on your
slow down.
heart.
Yeah.
Yeah.
So you need to be worked up for that. And the restless leg syndrome part, we call
So
this
let me ask you one more question on the sleep apnea, and then we can move on
Mhm.
to the restless legs. So the sleep studies, I've seen some ads. People are offering sleep studies at home. I'm hoping under the supervision of a physician. But how do the sleep studies in the office or a sleep lab compare to the sleep studies at home? Is it a viable alternative? People can rely on that for acceptable results.
Yes, so home sleep studies are, or type 3 device, using type 3 devices or any other which is approved by American Academy of Sleep Medicine is a very fair alternative to doing a lab sleep study. The devices are very accurate. Some of the new proprietary devices actually can also stage the sleep. They can give us the stages. The main difference is we tend to do lab sleep studies in people who have advanced cardiovascular or pulmonary problems, like advanced COPD, or they're already on oxygen for several reasons. The lab sleep study does have a technician available. So if there is a problem with their flows, the sensors are not working properly, they can be troubleshoot. Versus if you do a home sleep study, it is not as detailed as a lab sleep study. So certain patients, we do need lab sleep studies, but most of the patients currently who are screened for sleep apnea, they are good enough to be screened by home sleep tests. Those home sleep tests can give us most of the information,
So the
except that it is not a test that is meant to rule out mild sleep apnea. So if your clinical suspicion is still high that person A has sleep apnea, but a home sleep study is negative, the story should not stop there. The story does not end there. You should do more investigation with the lab sleep test.
So the bottom line on the sleep apnea is if you have snoring plus something else, like you mentioned fatigue and daytime sleepiness, or you stop breathing at night and someone notices that, then you need to see a sleep specialist. There's no other way around it. So these things that people are selling, I've seen some people selling these nasal things and some other home devices on Amazon, like without getting a sleep study. If you're snoring at night, start using those. You don't recommend that.
They're not meant to treat sleep apnea. They're not FDA approved. Now, if you talk about a lot of people are reluctant using a CPAP, thinking about mask being on their face.
Mm.
Roughly speaking, Ahmad, about 70% of patients have trouble getting compliant with the CPAP. There are alternatives. There are FDA approved, study proven, scientifically proven alternatives. For example, some oral devices which are not generic oral devices, but they're custom made for certain patients because not every patient is going to get benefit from oral device and not every oral device for every other sleep apnea patient.
Mm.
So by oral device is what I mean. You put something like a night guard, you put it in your mouth, so it may have different purpose. Some of them can push your mandible forward, some of them can retain your tongue forward. So there are different kind, and that they depend on what anatomy you have in your oral cavity or the back of your throat. So they can be brought up. Then there are newer innovations like Inspire device, which is like a pacemaker. You put it under your skin, and it's been advertised heavily. And a lot of patients ask me that. When I was in training, it was very costly, not approved by most of the insurances, and had a very strict criteria. The criteria has been more lenient now. It has been adopted by CMS and by most of the commercial insurances. The criteria, when I say it's lenient now, the degree of sleep apnea used to be the age cutoff, the BMI cutoff, how obese you are, have been more lenient nowadays. And the more evidence is showing it works. So the way it works, it is placed under your skin like a pacemaker, and it stimulates your tongue, your hypoglossal nerve, which stimulates the tongue. So tongue is also a muscle, as we know, that when we sleep, especially on your back, the tongue is pushed back and obstructs your airways more. So this device stimulates the tongue. So tongue is pulled forward, but it has to be approved for only certain kind of patients in which the airways are closing anteroposteriorly, not circumferentially, not laterally, because the tongue is at the base of your throat, is going to pull the airways forward. So if anybody is closing airways, like this device works amazingly. And it is approved for people who have tried CPAP or other forms of treatment and it has been ineffective or they're unable to tolerate it. Yes, Inspire device is their way to go. Insurances cover it, but we need to see those patients and evaluate them if they meet the criteria.
So does it work for central sleep apnea as well, or just for obstructive sleep apnea?
So central sleep apnea is not an airway problem. It is a
So
central
that's
problem. So
gonna
it's
help
not
with
an
that.
overweight.
Not gonna
So
help.
central sleep apnea, if you want to go into details, there are other treatment options for that.
That's all right. I know we are
And
running out of time.
that's not very common. That's not
Yeah.
very common problem. We see in certain group, certain populations, certain specific populations and groups.
Okay. Let's just talk briefly about restless legs. A lot of patients complain about that. What are some of the things that cause restless legs? What are some of the home remedies or treatments that you use to treat the restless legs to help people sleep better at night? This will be our last question, and then we'll wrap up.
Okay, so restless leg syndrome or Willis-Ekman disease is it's a complex neurological, sensory and motor complex problem. Basically, there is patients, how the patients describe to me that said they have an urge to move their legs, and that urge is not relieved except when they move. And the symptoms tend to happen mostly close to bedtime or in the evening. And the scientific basis for that is that as we go through the day, our dopamine stores are depleted. And the pathophysiology behind them is actually also dopaminergic system abnormality in the brain. The dopamine is a neurotransmitter released in the brain which regulates the motor control, the fine motor control of the body. And there at least one area, substantia nigra in the brain. It's a specific area in the brain which has rich iron stores. And iron is required for the functioning of this dopamine system. And that's why we see in end-stage renal disease patients or in pregnant women where there are depleted iron stores, repleting iron does tend to help these patients' symptoms quite a bit. There is another component, is the sensory input, which is basically coming from their peripheral nerves, in which there is an abnormal perception of those feelings in the legs. For example, patients may describe that they have bugs crawling over their legs, or they have a sensation of coke in their veins, and or they have just an urge that they can't stay still. It can be in one leg, it can be in two legs, it can be in arms, it can be in legs. Really, it's a clinical diagnosis. So once you diagnose it, the treatment is mostly, first thing to check is it's the iron stores. If the ferritin level, even if they're not anemic, if their iron stores are low, it means that their brain iron is going to be definitely low, and replacing it with iron does seem to help significantly. After that, if they don't get better or their iron levels are normal, you can try dopamine agonists, obviously carbidopa, levodopa. They do have their side effects that falling out of favor because of augmentation that they develop with, which is when you give them the medication, the symptoms actually get worse. Or they stop working, or you keep going up on the dosing and you keep going up on the dosing, the symptoms keep getting worse, or the duration of symptoms increases, or they start having daytime symptoms more and more. So there are ways to treat that. Most of the people now, most of the sleep physicians are using other medications, gabapentin, which are FDA approved for this purpose. There are some long-acting medications with the same mechanism of action. There are some patches available. And in certain very refractory cases, opiates tend to help too. So really, it is a therapy that should be individualized, and every patient is different. Sometimes we have to cross titrate the medications. Sometimes we have to, there are pramipexole or ropinirole. We have to understand which medications are safe for end-stage renal disease patients, which medications have to be used in what doses, how you titrate the doses. So it's a problem that I tell my patients to just have one physician managing those issues, and not to go from change between primary cares and sleep or nephrology. Let one doctor manage that problem, because it is a lifelong problem, and unless it's iron deficiency related, iron stores deficiency related, so tend to do better. And there are some therapies, some physical therapies or some exercises may help decreasing the severity of symptoms. But do medications do tend to help a lot.
Yeah, and being a Pakistani, I can't help you ask about home remedies. So, any home remedies that help you with restless legs? People have used some sprays, some magnesium stuff, some drinks, anything that you have found useful.
Magnesium, now you asked that there is some evidence that magnesium does tend to help with RLS, at least because of the way it works at the muscle fiber level. So there is some evidence, and that is too, if patients with insomnia related to RLS, they tend to seem better with the magnesium supplementation. I have patients who
Oral
told me that
supplementation or even topical is okay.
I have, yeah, that's what I, oral, yes, have been tested, but I have some patients who have come and told me that magnesium sprays tend to do work for them. Again, if you ask me what is my scientific opinion on that, jury's out there. I'm not gonna recommend for or against it, but if it works for someone, a lot of patients like tell me that drinking hot milk really works for their COPD. I said, sure. If something is working and it's not going to harm, go ahead, go for it.
Yeah, at least it's helping the milk industry.
Our farmers.
No, I appreciate you. Thanks a bunch for your time. This was really enlightening. I learned things that I didn't know before, especially about sleep apnea, restless legs, all the mechanisms that you explained. Very enlightening. And thank you very much for taking the time out. For our audience, if you found some value in this podcast, please share it with your friends and come back for the future podcast. And if you think it was too detailed and it was boring, then you can use it at night to help you sleep better. So either way, this podcast is going to help you. Thanks for listening and hope to see you in the future podcast. Happy living and happy learning, everyone. Goodbye for now.
Bye. Thank you.